Welcome everyone. This is Dr. Barbara Fisher. Good afternoon and good morning, and thank you for joining us today. Before we get started, please remember that this is a listen-only call, which means that I am unable to hear you. If you have any questions as we move along in our call, please reference the box that you should have at the right side of your screen that should have popped up when you logged in. That box will allow you to send questions over to me instantly. And if I am able to incorporate those into my talk at that moment, I certainly will. However, please know that I will address all questions at the end of today's call and have made some time available to do that. If perhaps there is something that you would like to speak to me further about, I will again be available immediately following today's webinar. So feel free to call my office at 586-323-3620. Again, that number is 586-323-3620. So to get started, the topic for today's discussion is going to be pediatric brain injury, why the academic piece is important, the need for neuropsychological assessment in the school setting. Pediatric brain injury is the last diagnosis to be made in the academic setting. The first diagnosis following a brain injury is ADHD. The second diagnosis is autism. The third diagnosis is oppositional defiant disorder. And the fourth diagnosis is Asperger's syndrome. The fifth diagnosis is finally brain injury, when an outside professional has come in, a neuropsychologist, and tested the child. Point being that when you have a child who has a brain injury, the first problem that happens is they're behaviorally out of control. They're hyperactive, overactive, thus the ADHD diagnosis. The next thing is the child's not relating very well to other people socially, thus the Asperger's diagnosis. So you have all the diagnoses, oppositional defiant disorder and so on, because of the behavior of the child. The first problem that we see following a brain injury is behavior. Why do you need neuropsychological testing? It's the only way that you can evaluate the cognitive problems the child is having. And the difficulty is that in the school setting, the focus becomes behavior. As a result of the focus being behavior, no one's thinking about the cognitive changes following a brain injury, and no one is addressing them for the child. So if we don't have testing that's done, then we can't recognize that. Now we're going to cover all of the different areas that you see on the screen. So let's start with ruling out other disorders. It's important to rule out other disorders because, as I indicated, there are so many other disorders that can mask itself as a brain injury. Again, one of the first diagnoses is ADHD. Case in point, there was a little boy that I evaluated in Paducah, Kentucky, and following his brain injury, he immediately went to his preschool and took all the little potted plants that were on the shelf and threw them all on the ground and broke them. His next label was ADHD, and he was on a stimulant medication that he reacted to. These children tend to react very different from what you would imagine with a stimulant medication when there's been a brain injury. And usually their reaction is one of becoming more behaviorally out of control, with a lot of emotional ups and downs that occur, a lot of emotional lability. Let's take a look at autism Asperger's. There's a difficulty acquiring language due to the problem of the frontal processes. How do we know it's not a brain injury? How do we know it's autism? Same is true of Asperger's. Oppositional defiant disorder is a very common diagnosis given in the school setting when there's a brain injury because the behavior is a problem. They're not rule governed. Behavior becomes more problematic over time because with pediatric brain injury, contrary to what we've believed in the past, it doesn't get better. It gets worse over time because of the changes at a cellular level. Then compare the symptoms to that of the brain. Hyperactive, impulsive, pragmatic skills. How do we know that those symptoms are due to brain? How do we know that they're not due to the other disorders that are listed here? The difference is neuropsychological evaluation. In the school setting, they're going to take the symptoms that they see and make the diagnosis. They don't have the neuropsychological tools to make the diagnosis by testing. So the important thing is to recognize that there's been a brain injury. The school cannot treat what they don't understand. Pediatric TBI. What happens when there's a pediatric injury, especially if it's early, it affects the building block grades. These children have intermittent learning. They may be having a seizure at the time they're trying to learn something, so they just miss the information. When they're having a seizure, they miss information as the seizure is beginning, during the time of the seizure, and afterward with a period of disorientation. As a result, they'll miss little pieces of information that they need to form the building blocks for the learning that's going to follow. The first 3 grades, 1, 2, and 3, are the building block grades where they're learning the foundations that they need for 4th, 5th, and 6th. Then what happens is they get to the 4th and 5th grade, and they don't have the learning to support what they're trying to learn in the 4th, 5th, and 6th grade. And no one understands. No one understands enough to go back and pick up the pieces that are missing. And on top of that, if there's a memory problem, then again, their learning is going to be intermittent. It's going to be complicated by the deficits in the brain, and as a result, it just spirals downward. So with pediatric brain injury, they get worse with every year in school. When there is a bright child, the problem is not obvious, especially when they're young. And there are numerous cases of children that have had a brain injury. But the problem is that they were young at the time. And we had one particular case that we followed from the age of 4 years all the way up to 12, 13 years through the 6th grade. And this child looked wonderful in the school setting. They couldn't understand why she had a brain injury. But in the meantime, I was tracking her process and her development through that time, and there was about 4 or 5 different reevaluations with the same test measures and then new test measures, and then upward scale versions of the test measures based on her age changes. Just at the time when she was 13, the test measures were starting to change dramatically. She was diagnosed with a seizure disorder that had, at that point, permeated the whole brain from the point of where the fracture had occurred. But more importantly, it wasn't until the 6th grade that finally her learning problems were very obvious. Prior to that time, despite the fact that testing was documenting problems, despite the fact that the brain was obviously changing, so by the time she had a EEG, the whole brain was involved. Despite all of those issues, she still looked all right in school because she was gifted. She took all of her cognitive reserve and all of her abilities to work through the deficits. So as a result, she appeared average. When you're in a school setting, average is okay. The point being on this slide is that long-term results of pediatric brain injury, there are cellular changes over time. And so as a result, pediatric brain injury gets worse with time. It does not get better. It's important to develop a treatment program for the school. The schools need the help of outside professionals. They are not taught neuropsychological evaluation. It is just beginning to show up in their school curriculum programs in teaching teachers how to teach, and they do not typically have neuropsychologists on staff. So they don't understand the brain. It's not their fault, but as a result, they don't understand what they're looking at. And they try to approach language problems from a more linear approach as opposed to a curvilinear looking at the whole picture. And as a result, if you're not teaching a child based on their deficits, particularly when the frontal area of the brain is involved, they're not going to learn. So I cannot tell you how many children we have had where they have been in a school education program being taught language with special services, certified for speech and language. And by the age of 10, 11 years old, they still cannot read or write. Because if you don't know how to teach them, they're not going to learn. And so we see all kinds of language problems that show up in the school system that they don't really, A, know how to measure, or B, understand, because you have to look at it from a brain behavior point of view. There's issues of reading comprehension, they dislike reading, they're contextual readers, and then move all the way to the aphasias, where they're literally having dyspraxia as opposed to pragmatic social conversation, language, being able to communicate their thoughts, word retrieval, phonological processing. They don't even know language on the very basic level. And then malappropriatisms is where they're constantly using the wrong word for another word. And these are all issues that are very characteristic of injury to the brain that you can't expect the school to understand. It's up to the outside professionals to come in to help the schools in this endeavor. And a case in point to that is at our facility in Neuropsychological Services, we write very, very in-depth reports, and we write prescriptives after each area that we're evaluating. And I had a case in Delaware where they had all of that information, and they literally developed the first traumatic brain injury program in that school system for this one particular child to address the deficits. The parents were very involved in the school system and very well liked by the school system. Both parents were teachers in the school system. The problem is they didn't know how to implement it. So by the time that I came to the school to lecture to them and do a seminar and explain exactly what had been written in the report, the child that I had evaluated, that the whole program had been planned around, was flunking out of the traumatic brain injury class. It wasn't working. And it was because even though they had put it into place, they didn't know really how to implement it because they didn't have an understanding of brain behavior principles, which we can't expect them to have. Failure to develop failure to develop language is the first sign of injury to the brain. So if you have an early birth injury, if you have an injury due to something that happened in the hospital, resulting in anoxia, you know you're going to hit language, you know you're going to hit the frontal processes. Any sort of reading language deterioration or lack of progress in learning language is the first sign of injury to the brain. These are the kind of articulation errors. This happened in a little boy who was 2 years old when he had the injury, where he had a skull fracture in just about every area of his brain. He had multiple skull fractures. Brilliant child. At the age of 3, he was not intelligible. You could not understand what he said. At the age of 5, when reevaluated, you still could not understand what he said. And yet some of his test scores were in the very superior range. So he was a very, very bright young man, but he was unable to develop intelligible conversations, and he was not intelligible because of the problems affecting the frontal area of the brain as well as the other areas of the brain. And even though he had been receiving training through that time, again, if you don't follow brain behavior principles, there's no one that can teach that because it's not going to get through. So an example of that was he had a guitar was G-dur, he would use words like you see Petzl, and then there for ambulance. I mean, there's no way to attempt to figure out what he was saying because he didn't follow any rules. The other two examples, one is of malappropriatisms. They use sloppy for sloppy, instruction, inscription, those kinds of things, or basically homonyms. He couldn't bear the pain to understand different versions of the word. These are all problems that these kinds of children have when they have an injury to the brain. Reading errors are not predictable. So, for example, a young man read the passage, he is a friendly animal, a famous winner of dog shows, as a federal animal, a famous winner, and you see below, see the black dog. So there's no way to predict that. Whenever you see that, you know that something's going on in terms of the brain because there's no rhyme or reason to it. These are more examples. This is on the Aphasia Screening Test, and the same thing occurs when you're attempting to spell. Spelling errors in writing, these are two more examples of that. Again, whenever you're looking at something and you can't read what they said, think brain. More examples of spelling responses. Now, some of these examples I'm giving you, the school had in their testing, but they didn't know what to do with it. So they have labeled this young man having a speech and language disability, not brain. And he had all this training, speech and language from a young age because he had had an injury to the brain at the age of 3. This is a young man where the parents were teachers, and this is what he looked like when he was 12 years old. Language comprehension is different, plus pragmatic skills, which is the social skills. So again, one of the reasons why these kids are labeled defiant, socially out of it, or Asperger's is because they don't know how to communicate their thoughts. They don't get the use of idioms, sick as a dog. I think I'll hit the sack. They think they're hitting a sack. They don't get proverbs. They don't understand the subtleties of language. When it comes to understanding language in terms of math vocabulary, they don't get it either. And they don't get in terms of language when they're reading, similar to the differences between words and how they're used. And the picture goes on. Expressive is always worse than receptive. They have an output problem. They don't understand classification. Their sentences ramble on, and they're not even coherent, and the thought just disappears. The same thing happens when you're talking to them. They start with one sentence, and they finish with another sentence. So it's important to do a neuropsychological evaluation to provide teaching suggestions based upon brain behavior principles that are clear and precise for the school to understand. So we do a full evaluation with a treatment report and a forensic report, and it's in the treatment report that we evaluate all these areas. What's going on neuropsychologically with two basic batteries, their cognitive status, their achievement functioning, their language processes, attention and concentration, memory, visual spatial, visual perceptual, visual motor, because all of those can affect reading, sensory motor processes, as well as executive reasoning and adaptive functioning. So we go through each of those areas, and then in each area make specific recommendations in the treatment report by our neuropsychologists on staff and the rest of our staff for exactly point by point what can happen in the academic setting, which can be applied by individuals if they understand the brain. And that is where sometimes it's helpful when I've traveled to the different school systems and done seminars for them. So these are, I teased apart a few areas for you, like the language processes. We're looking at all the language processes: receptive, expressive, oral and written language, reading skills, reading comprehension, social, pragmatic skills, auditory, verbal, and phonological processes. So we're separating out all those areas and looking at how the child's functioning in all of those different areas, and then making suggestions to the school. Attention and concentration, same thing. Memory, separating out, is the information getting in for verbal and visual? Working memory, are they able to retrieve it? Are they storing it? Can they recognize it later? Are they getting confused? Sensory and motor processes. And then executive reasoning, there are some specific tests for this, very, very few. You're really tracking deficits through all of the evaluation that you're doing in the specific areas of the frontal processes. Early injury to the brain, you can pretty well guarantee you're going to hit the frontal area of the brain. The last area of the brain to be formed, not totally formed until between the age of anywhere from 12 to 15 years. So basically know that if that area of the brain's not formed, it's those connections that aren't together that are going to be disrupted when there's an injury. The frontal area of the brain is known as the area of civilization, social intelligence, adaptive functioning. And when that's not there, you have the children that are wild, out of control, impulsive, defiant. That's why they diagnose them as ADHD, oppositional defiant disorder. They classify them as emotionally impaired, and then they tuck them away in the back rooms where basically they're just dealing with them behaviorally, and no one's addressing the cognitive functioning. I'm going to tell you a story about a little girl. She originally had a hearing problem. And when she was 1 year of age, she had lost her hearing totally. So she was hearing impaired, and she was deaf. In the school system, they took her and they literally took her under their wings, and they taught her sign language, and then they taught her how to talk by reading lips, and they taught her how to talk in forming words, and you could actually understand her. And this was her story. So in the first grade, she was in the first grade with all these other kids, and they all participated in sign language. She was very connected to the classroom, and she was functioning at a first grade level with that of her classmates when she got hit by a truck. When she got hit by a truck, she had to have a plate in the frontal area of her brain. Later on, when we did the PET scan of her brain, she had practically nothing left of the frontal area of the brain. It was so bad. The MRI showed all kinds of impacts to the brain. There was very little left in terms of connections in the frontal area of the brain. However, as she was progressing through school after this injury, initially everyone was very concerned about it, but then it faded away because they didn't understand what to look for. By the time that we came in and evaluated her, when she was in the 5th grade, she was an outcast from her school. She was a total behavior problem. She was sexually promiscuous. She was grossly overweight. and nobody wanted anything to do with her, and they were simply trying to control her behaviorally. And all of the classmates were shunning her. She couldn't read or write, and barely could communicate and talk. It's a very, very sad story. The point is the school didn't understand the brain injury, and they lost sight of the brain injury, even though it was very traumatic when it happened. And all that was focused on was her behavior through this whole time. The frontal processes are the supervisory system. The communication manager, the director of operations. It's the highest level of brain functioning that allows us to take in information, process it, and use it. The main symptoms that you're looking at for the frontal processes is selective attention, not getting stuck on the irrelevant, sequential analysis, understanding step by step, cognitive flexibility, being able to have creativity and not get stuck in concrete thinking, integration, seeing the big picture, and the ability to control one's emotions per the situation that one is in. Example of impaired frontal process selective attention. What happens to these children is they pay attention to everything. And then, of course, they pay attention to nothing because they're always overloaded. This is the kid that walks into the room and says, wow, look at this. Oh, my gosh, look at this. And they're anywhere and everywhere all at the same time. Well, what's your first thought when you see a child like that? Hyperactivity. And that's exactly what happens. They get overdiagnosed as ADHD. However, if you were to track them in terms of what they did thinking-wise, you'd see that they had intrusions in their memory recall. So what happens is they're thinking one thing, you're saying something else, and they get the two confused. And so continually what they think they've heard, you didn't say. And there's always a problem in terms of what was said and what was heard. An example of that was a little boy that I had tested, and in response to courage, it was a vocabulary test, he gave the definition that it was sword and stone. And so I said to him, well, I don't understand how you get courage in Sword in the Stone. Well, he was watching the movie Sword in the Stone, and the boy took out the sword out of the stone, and they said he was courageous and had courage. These are the kinds of things that take place. And so the problem is that once something's learned, it gets stuck. So they think something, they attach it to something, and then it's there forever, and it doesn't move, even though new learning comes in. So even though he was tested again on this same IQ test for 3 years in succession, he still gave the same definition, and you knew that somehow the word courage had been covered in school. The other thing that's important is that they're easily overwhelmed by too much stimuli. So these kids really act out the noisier the classroom gets. So imagine them in a typical school setting, and then you know why they're going to look like a behavior problem. Sequential analysis. It's very difficult to learn language, to understand how words are spelled together when they don't get the sequential process and they can't integrate it. Part of that's going to be due to a visual spatial issue, but part of that is just simply going to be due to the fact that they don't understand how letters follow another. So what's going to happen when they're trying to learn spelling? They're trying to sound out words. I have a school for frontal lobe disorders, and we just we wrote a letter to one of our teachers. Her dog is dying, and so we wrote Miss Nancy a letter. And the one boy who's 15 years old, who's been in our school now for a while, wrote a line, and you could barely read it. I mean, it was certainly better because when he came to us 3 years ago, he couldn't read or write at all. But it's still very much a problem, which means we're back kind of tracking exactly what we need to do to change the process for his training. And so the point is that we're always reevaluating, relooking at what we need to do to change how we teach, because it's very hard for them to learn because of this issue of sequential analysis, frontal processes, and then how the rest of other issues involving the brain kick in. So any step-by-step direction or instruction is difficult, but where you really see this impact is language. Cognitive flexibility. These individuals are very concrete. They get stuck, so they don't get the big picture. They get stuck on very concrete sentences. So you will tell them to do something, and you're really kind of teasing them, or they don't get the subtleties. They don't get the punchline of the joke, and they think that you mean exactly what they're saying. At the same time, they can't inhibit or shift sets, so you will be having fun with them and teasing, and then you're done. They're not done. They keep going. These are the same kids that they don't want to go away on a vacation and then they don't want to come home. So it becomes difficult to work with them in terms of emotions, but also problem solving and generating solutions. And so you say, well, you just tried it, it didn't work, why are you trying that again? If they don't know what else to do. Integration is another issue. We had a case one time in Chicago where the mother said, I have to teach this child every new thing he learns, and it was true. He couldn't apply it. He couldn't take a concept and then apply it to something else. So what frequently happens with math is you'll teach them the math concept, but the minute you change the problem, they think it's a whole new problem. They don't get it. And these are the kinds of things that happen. So they don't get the similarities. So they can't generalize learning. They don't have the ahas. You have to teach every single thing. And then if you give them too much at one time, they're overwhelmed and don't remember any of it. So this is the reason why if it's not clear that it's a brain injury, they're not taught a certain way, it's really almost impossible to teach them in an academic setting because we're struggling with it, and we're all trained in brain. And you can imagine what's happening in the regular school setting. It's very difficult. And then you have all the emotions that come into play. So every day, the child may come in one way, then it can come in very differently, depending on how they slept the day before. They have a deepened emotion, and once they get emotional, they can't get out of it. They can't shift, because again, it's the shifting steps. So once they get mad about something, they can't shift. And then they're misconstruing information. So they get upset about that, and there's no way for you to predict that because you don't know what it is that they're thinking, because you would never come up with the same meaning from a certain situation. In addition to that, then you've got the right frontal processes that aren't regulating emotions. So you've got so many issues on so many different levels that you have to tease apart with the child just to explain their behavior on an everyday basis. And it doesn't get better, it gets worse as they get older. Life gets more social and more complicated. So how do we apply those deficits from the brain injury to the school setting? Well, here are some examples. Early signs at school, if there's a frontal lobe injury to the brain, there's changes immediately in their handwriting, their coloring, their copying. You'll see some of those lost moments in time. It's not always a blank stare, it's just where they kind of get frozen and they repeat the same behavior again and again, which would be more consistent with a complex partial seizure. They can be emotionally labile, up and down, oppositional defiant. They can have falls and clumsiness because their motor skills are off. They don't recall recently learned information. What they learned today, they forget tomorrow. And then their grades go down. What do we see in elementary? Language is the biggest issue. Acquiring math concepts. And these children have a really hard time with money and time, classification, understanding abstract concepts. We were trying to teach evolution in our school setting. And these kids, they had no concept of evolution, and they weren't going to get it as an